Good morning, ladies and gentlemen, and Chairman, Prof. Niva. Thank you very much for your kind introduction. Academy for Silent Mentor actually been set out as a non-profit, independent education and research institution. So one of our key focus is on research as well. What we have done, sorry, the slide. Yeah. So we actually run a rapid tissue donation program through our Silent Mentor program network in Malaysia. And our chief supervising scientist is actually Prof. From Sunway, from the HMC. What do we know about this rapid tissue donation program? Is that we have to harvest the tissue fresh. What we have learned in the past in University Malaya, when I worked with Professor Teo from the Cancer Research Malaysia, during the time when I run the Silent Mentor program in University Malaya, we look at tissues on the Silent Mentor after death. However, that was harvested after we had done the deep freezing. And we found that deep freezing itself actually destroyed all the DNA of the cells of the body. Hence, we will not be able to isolate any meaningful data from those tissues. This moved on, and when we set up the Academy for Silent Mentor, we seriously look at how we can facilitate future cancer research. With that, we look at if we harvest the tissue fresh within 2 to 6 hours after death, when the patient or the donor actually arrive at our training center. And we also have a state-of-the-art biosafety theater, whereby the whole theater complex is under positive laminar airflow, with the air being sterilized with HEPA filter as well as ultraviolet C. So we actually work in an environment that is free of contaminations. In that kind of clean air environment, we can actually instantly harvest tissues from the donor. It makes it easier, of course. I'm a surgeon and a minimally invasive surgeon as well, so I can use my laparoscopic equipment or open surgery to immediately harvest the tissue from the donor, and then immediately we store at a -80-degree freezer. So that is what we set up for the rapid tissue donation program. And of course, the beauty of this is that most of the time, as you clearly see that in Malaysia is a hotbed for clinical research, there are a lot of donors. In fact, most of my pages on Silent Mentor program, we call Silent Mentor program now, because we actually offer end-of-life care as well before they actually pass on. So we actually get to know before they pass on. So there is an opportunity for us to positively engage with them. And we found that more than 50% of patients are actually having cancer. And all of them have terminally cancer. They are all terminally ill. So there is an opportunity for us to actually engage with them, counsel them, talk to them, not only about body donations. Clearly they have made up their mind about donating their body after death. And clearly they know that they have terminally cancer, and they are preparing to face death with dignity and future contribution to the society. Yet there's another milestone. They can make another step forward and think about, can they actually donate the tissues for future cancer research to benefit cancer patients like themselves in the future. So this offers us an opportunity for us to actually explore this avenue of getting tissues for cancer researchers. So in that sense, when you look at live patients, they have primary tumors, and towards the end of the treatment, despite all the target therapy, the cancer cell would have spread to different parts of the body. And our main challenge as a clinician is that it would not be ethical for us to harvest those metastases just purely for academic purpose, because it will not add any benefits to their end-of-life care. So in that sense, we lost a huge amount of scientific data that we do not know what happened to these patients' cancer cells. How did they actually evade those target therapy that we clearly have and clearly having a clinical trials in the country, and why many of them, despite having target therapy, still eventually break down and then they have metastasis everywhere. So that kind of information is what we lack, and that kind of information that we keep telling our patients that you can help the future cancer patients. And a lot of them actually sign up for this program in our data. Last year, we have 1,000 preachers sign up, and majority of them would be in a position to think about this rapid tissue donation program. So our objective of all this network that we try to set up is actually to explore the understanding of how the tumor behave. Why would they spread to different parts of the body, and why would they, each one of the metastases, why would they behave differently if they behave differently to the primary tumors as well. I'm a surgeon, so I always got a referral from my oncologist, and they told me that I've tried everything, target therapy, but the cancer still spread, and there's a metastasis. Can you go in laparoscopically and take out that metastasis? In the past, I would say no, because it's not going to benefit the patients, right? I'm not able to clear the cancer, and definitely not going to add any benefit to the patient, and apart from introducing post-operative pain and complications. But the key thing is that nowadays, with advancements of target therapy, the oncologists actually want to know what happened to these metastases. Are they the same as the one as in the primary, that they have the data before? So my aim of the surgery was to go in, harvest the metastatic tissues, and then send for next generation gene frequency to look for markers that allow them to kind of titrate their treatments. So in that sense, all this information become very important. And towards the end, if we can fill out the gap again after the patient passed on, that we can actually get some more information down that pathway. You can imagine that kind of information could be a breakthrough for our cancer treatment. So this is the kind of thing that we are trying to look at. But however, we're not only looking at cancer patients. I actually have terminally ill patients with motor degenerative disease, that they know that the days are numbered, and they have signed up the body donation program. But not only that, they ask me, can I actually donate the brain tissues for future research? So these are the kind of pressures that we have that encourage us to pursue further in the field of research. And we talked about precision oncology earlier on. And one of the key things that we know why the rapid tissue donation program works is in United States. There are 20 centers that run the rapid tissue donation program. And because of what they have done, the rapid tissue donation, they clearly understand about how the lung cancer cells metastasize. And with that, that's why you can see that currently the lung cancer has a spectrum of target therapy because of their understanding of this lung metastasis from the primary lung cancer. And you can clearly see that those who have the biomarkers, and then if you have the target therapy for those with non-small cell lung cancer, their survival rate actually much better. And all this made possible because of the rapid tissue donation program in those 20 centers in USA. So what do we do when we look at our program in terms of the enrollment? So we actually have inclusion criteria. All this has been approved by our independent scientific and research committee within Academy for Science Mentor, as well as our independent ethics board. So we look at the inclusion criteria for our appraisers. Of course, they have to have a histological diagnosis of cancer, and they have to be at the end stage of the cancer, and more importantly, they're able to give a consent before they pass on. And of course, in terms of logistics, they need to be near to our training center where our theatre is, because we need to transfer them from home to our center within 2 to 4 hours. So, and of course, if they have, one of the key things is that if they have infectious disease, then we will exclude them for our silent mental program, Hep B, Hep C, and HIV, so we do screen them for them. At the time when there was a COVID time, that is when we have a soft launch of this program. And you will be surprised, during the COVID time, actually a lot of cancer patients sign up for this program. And but because of the COVID, we really have to screen them. And in fact, we screen them with PCR and an antigen as well. And after they arrive to a training center, and only then we start harvesting their tissues. So you can clearly see that at the time of the most challenging time that we actually managed to harvest the tissues for this program. So nowadays we do not actually have to screen them before they come in. We actually just do a screening on site. And then if they become found that they are positive, I think COVID-19 is not much of a problem for silent mental program now. We still receive them and deem safe to actually carry out the program, even if they are COVID-19 positive. I won't go into the detail of that, but you can clearly see that we have a minus 80-degree freezer here, and this is our theater, and when they arrive, we carry out surgery, and I have my student council member who will come in to assist me, and within a very short notice, and then we harvest the tissues and put into the minus 80-degree freezers. So this is what we can do at the center. And to date, I must say that we just had a soft launch, so we haven't really worked with many collaborators. We hope that we can work with Cancer Research Malaysia or Clinical Research Malaysia to actually pursue more. What we need is a structured research project that we know exactly what kind of tissues we want. So at the moment, basically we have this intra-abdominal follicular dendritic cell sarcoma, which is a very rare tumors, and we managed to harvest tissue from the primary tumors, the pleural metastasis, and the liver metastasis. And then and one thing is that we also have very rare tumors like the metastatic desmoplastic small cell tumors that's metastasized to a lot of different sites. So of all the sites that we identify on the PET scan, we will harvest those tissues and store them away. So these are the prospective collections. Their tissue remain in our freezers. We're looking for researchers who are interested to carry out further genetic research on the tissues. So we also have very rare tumors like small cell neuroendocrine tumor of the rectum with liver metastasis and colorectal lymph nodes. So we actually have a sample on the liver metastasis, the subcutaneous nodules, the metastasis on the abdominal wall as well, including the axillary lymph nodes metastasis. We don't know why the tumor actually metastasized to the axillary lymph nodes, but I think it's go through the subcutaneous tissues, and of course the primary tumors from the rectum that we actually excise. And these patients, when he had a primary diagnosis, already metastasis, so she actually did not have a primary surgery. So that will be the initial primary tumors with all the metastasis cells being harvested. And of course, we have quite a number of patients with lung cancers which are resistant to the target therapy. And of course, we have all the metastases, like the lung cancer metastasized to the breast. So we have the breast metastasis, with the augmented metastasis, with the chest wall nodules metastasis, with the pleural metastasis, with the peritoneal metastasis, and with the adrenal metastasis as well. So all the different site metastases we have harvested. So these are the kind of thing that we actually harvested. And of course, there will be a lot of ethical consideration when we pursue for donations. It would be difficult for the primary care physician to actually talk to the patients, because the moment you talk about this, they will say that, do you mean that I'm going to die soon? And, or if they are having cancer, do you mean that I have no chance of any treatment, that you have decided that you will stop treating me and offer me just for a guinea pig for future research? So it's very sensitive issues. So we find that it's quite challenging. And I found that personally, that it is much easier to go through the silent mentor program. And I can share with you my personal experience with one of the donors later on. And of course, communications would be most important. And with the support of the primary team, it's very important so that there is a good understanding. And of course, in terms of religious belief, that you really have to overcome that. And I think in terms of Islam, it's difficult to donate body because you need to bury the body within 24 hours. But rapid tissue, I think, is feasible because they can come to our center in the clean air theater, harvest the tissue, and then we can immediately transfer back the body to the family. So it can be done in such a way. So there's a lot of ground that we can actually explore. In terms of the program, it's really expensive, of course. And the biosafety theater and all the equipment is very expensive. Thank God we have volunteers. So myself, I offer my time, and Prof as well over there offer her time as well to Academy as a trainer. And we have a lot of student volunteers as a student council member who will come at any time to assist us to harvest the tissues. So in terms of the most difficult part, I think, is the financial constraint. It is really costly to do a genetic analysis. And of course, when you do a genetic analysis, there's a lot of control. We need to protect the data. Data protection is very important as well. So our ethics board is really going through this, and then we are really clear about what we would like to do with our data and how we are going to protect the data for our donors. So this patient, when he came to me for a second opinion, because he has a very rare tumors, and when he initially presented to her primary physicians with a left loin pain, subsequently were found to have a very big mass at the left iliac fossa, and had a diagnostic laparoscopy and biopsy of the peritoneum and nodules over the small bowel. And this is the CT scan of that big tumor mass. It was a diagnostic challenge, and initially it was thought that it was actually a GIST tumors. So in the end, he was treated as such, and unfortunately, subsequently, he had intestinal obstructions and had a transverse loop colostomy by a primary team, and then during the laparotomy, they did another biopsy, and this time it was sent to Prof. Pamanatam in Subang Jaya, and found that in fact it's a follicular dendritic cell sarcoma, which is an extremely rare tumors. So he then complicated with GI bleeding and came to me for a second opinion. And at that time, it was quite sad because I explained to her that the tumor actually has spread to the liver, to the lung, and you're clearly having GI bleeding that cannot be stopped. And there's no options of surgery. So at that point of time, she looked at me and just said, Prof. Chin, can you tell me exactly what you can do for me and what you cannot do for me? So when I told her the bad news, that I'm very sorry, there's nothing that I can do for you, you know. And she was very brave. She said, oh, it's okay, I can accept that. But so I was thinking that, should I ask her for tissue donations, you know? And at that time, it was in HDU, so I thought, I better wait for her to go to the ward. And eventually, I went to discharge her from the ward, and during COVID time, the family couldn't come into the ward. So I look at her, then suddenly I pick up my courage, and I talk to her, do you think if you can donate the tissues to benefit future patients with similar cancer, would you be interested? And she immediately looked into my eyes and said that, yes, I would like to do that. So I was quite surprised, but of course there is already a rapport between me and her. Then I tell my stepfather and said that, what if you also can donate your body? And straight away he said, yes, I would like to do that. Then I said that you need to talk to your son and family. So I went downstairs and talked to the son. The son was very surprised that mom actually made such a decision. And the mom actually said that they all listen to me, do not worry. I said yes, it's yes for the whole family. So in the end I said, okay, all been good, but then I cannot meet the family during COVID time, right? So I said, you go home first, I'll come and see you at home with your whole family as soon as possible. So after she discharged, so I went to her home in 2 days' time, and then I met the whole family, including her brother, who is a pathologist from Canada, who called in, and we'll discuss about the rapid tissue donation program and the body donation program. Thanks God, she lived near Gerast. So we were able to, in the end, she passed away. She signed a consent form very happily, and on that very night, she passed away peacefully. And the family said she just waited to sign this consent form. After she completed the task, she was so happy, and then she passed away in her sleep. And we managed to brought her in, and during the time when we were running a silent mental program workshop as well, that evening we brought her in, and then we straight away harvest the tissues. And we managed to actually isolate the tissues and confirm that by Prof. that we can actually do next generation gene sequencing on the tissues. So we managed to do that, and we are going to do more analysis on the metastasis. So I think the times is out. So basically, what I'd like to say is that what we can offer is a program that hopefully more researchers can collaborate with us so that we can make meaningful research on those tissues. We are a non-profit entity. We are open to all institutions in this country and in the world as well. Whoever needs the tissue, just come to us and we will facilitate them.